Thank you for inviting me to be here with you today. I'm just going to share my screen and get right into it. I like to say I have the half-hour version or I have the 4-day version. And so the half-hour version is actually much more difficult to crunch information into a short time. You're welcome to reach out to me afterward if I can be of any support to you, families and professionals. Please do reach out. So I'm just going to get right into it. To get you a shared definition of cortical visual impairment, or CVI, cortical visual impairment is essentially a neurological visual impairment as opposed to an ocular or eye-related visual impairment. Typically in kids or individuals with CVI, the eyes are functioning just fine and the child is getting a clean bill of health from the ophthalmologist or optometrist, and we're observing unique visual behaviors and visual differences in terms of access to visual information that are just unique and cannot be explained by anything going on with the eyes themselves. That's because CVI, the impact is in the brain and in the processing of visual information coming in through the eyes. We now understand CVI to be the leading cause of visual impairment, of childhood visual impairment. We used to say in developed nations or in the US specifically, but I think it's more accurate to talk about quality neonatal healthcare, because the primary causes of CVI are related to brain injury that tends to occur around premature birth, but also around conditions involving seizure disorders like CDKL5. CVI is completely different from other non-brain related or ocular forms of visual impairment. When you have a child with an ocular or eye-related visual impairment, you can basically look at the cross-section of the eye here up on the top left. If you have an ocular visual impairment, you need to know what the specific condition is. And when you know the condition, for example, glaucoma or a cataract or a retinal detachment, each of those conditions affects a unique part of the eye. And if we know what part of the eye is affected, we can basically guess the type of implication or functional loss that the child is going to experience. We need to know also how severe the condition is and whether it's progressive or stable. We can't do that with CVI because in CVI, the ocular structures tend to be intact or maybe have minor differences. And so we actually can't even look at a micro MRI or even a live fMRI to be able to tell exactly what's happening in the brain from a functional context. Neurology can really help us diagnose CVI, but not tell us much about exactly what's happening on a scale of severity and what the impact on vision is actually going to be. If you do have a child who has CVI and an additional ocular form of visual impairment, we just need to know how the two are sort of separate and what that unique ocular condition is, how it's affecting vision separate from the processing impact of CVI, which is what I'm going to talk about functionally with you today. Diagnostic criteria for CVI are more functional than clinical, which makes this a difficult one for clinical specialists to really look at and provide detailed diagnostic information on. You need essentially 3 diagnostic criteria to diagnose CVI: a history of brain injury or malformation. I'm going to talk in a minute about how that relates to CDKL5 specifically. You still need to have a comprehensive eye exam from an ophthalmologist or optometrist, or even a neuro-ophthalmologist. Usually that is to rule out additional or alternate ocular forms of visual impairment that could explain what we're observing in this abnormal use of vision or this lack of access to visual information. Most importantly, and this is why I say it's really a functional diagnosis, CVI comes with the presence of unique behavioral characteristics that are very different from the behavioral characteristics that are observed in kids with ocular or eye-related visual impairments. I'm going to get into that a little bit, and I'm going to share some resources with you about how to get further information about those characteristics. I wanted to touch briefly on CVI and the way that you might be learning about this from the CDKL5 community. We understand, and I certainly saw when I was at the CDKL5 conference in Denver and spoke with so many families of kids with CDKL5, who very large percentage of which clearly had CVI, whether it was diagnosed or suspected. There's obviously a strong prevalence of CVI in children and individuals with CDKL5. What I found from the research, and if anybody has further research basis, I would love to see it, is not really yet enough data to show a strong estimate in terms of the percentage of the population that have CVI, but we can say that CDKL5 comes with a strong likelihood of having CVI. The most likely cause is epileptic encephalopathy. However, the most common causes of CVI outside of the population of kids with CDKL5 is hypoxic ischemic encephalopathy, HIE, or paraventricular leukomalacia, PVL. Those are two conditions that we tend to see in children who are premature birth and very low weight infants, basically anoxic or hypoxic brain injury, lack of or too much oxygen going to the brain, which tends to be at high risk factors around premature birth. There's really not enough research to date on correlation between CDKL or between CVI and various different chromosomal and genetic disorders, but there are particular conditions that are showing stronger correlations. And within the CDKL5 community, you actually have a lot of research in comparison to other chromosomal and specific etiologies that really haven't dipped into this enough. So CDKL5 is actually a field and an area of study that has some terrific research already happening, both in clinical trial research as well as in various related fields. We've got prevalence research. One study that I found had 11 subjects. 100% of them were identified as having impaired visual function and not ocular visual impairment. That study called for more research and larger cohorts to be able to help determine possible prevalence in the population. A person with CDKL5, I see a question, can develop CVI later or congenitally, because most likely the cause is the impact to the brain coming from uncontrolled epilepsy, right? So from seizure disorders that are causing that damage in the visual pathways and in the visual processing center of the brain. I also found research that showed using vision as an outcome measure for progress. I saw mouse model studies, which is really a little bit beyond my scope as an educator, but is obviously exciting as it relates to clinical trials. And then I also saw studies that correlated visual impairment with developmental factors, which is not surprising because there is extensive research in the field of blindness and visual impairment that correlates access to visual information with development across domains. Lots more research out there. I think there's some really exciting stuff happening, as you all know, in the CDKL5 community, and there's a lot of great basis for research, a lot of great researchers out there. The most frequently asked question that I get from families is the clinical eye report, for example, from an ophthalmologist or an optometrist came out normal or unable to test, but I know that something's not right. You have observed your children, you can see that they are not using their vision in a typical way, and you may have even observed very specific characteristic behaviors that are unique. Yet the eye reports come out typical. Let me see, the one that I cited was for the mouse model was Lupori et al. 2019. I'm not super aware of the broader range of research out there, or the players, the people involved in that research. So you may be aware of other ones that are maybe equally relevant to you. But this is exciting because the mouse model study that I cited actually related to mouse models looking at visual impairment and looking at visual processing and the visual cortex in the mice, as far as I understood. So I pulled that one because I thought it was exciting and relevant to this topic. So what do you do if you get this question, right? If you have this question, the eye results are normal. Well, that makes sense because the actual structures of the eyes are normal. It's not in the eyes, it's in the brain. The first thing that I would say is do not assume that clinical vision specialists such as ophthalmologists or optometrists will recognize and diagnose CVI. Some do, some don't. Clinical vision specialists specialize, their expertise is in the ocular structures and the structure of the eyes themselves. So it's not necessarily in the processing of vision in the brain, although of course they get training in that. It's really not their diagnostic job. And so many are not necessarily comfortable with diagnosing CVI, which is, as I said, a more functional diagnosis. The first thing you want to do then is, before you even make the appointment with that eye doctor, reach out to their office and ask, what do you think about CVI? Is this a condition that you are comfortable diagnosing? Do you recognize it? Do you know what it is? Have you diagnosed kids with CVI before? If not, find someone who does. And I think I can't, overestimate this one. The amount of families that I've worked with who have found those visits to the eye doctor to be so frustrating, because there's clearly something going on with their vision, but they're just not getting answers when the focus is only on the ocular structures. That specialist might be a neuro-ophthalmologist. A neuro-ophthalmologist is essentially an ophthalmologist who has additional training in neurological visual impairment and may be comfortable diagnosing neurological visual processing disorders such as CVI. Most importantly, follow up clinical assessment with functional vision assessment. Clinical assessment can only get us really so far. It can get us a diagnosis and maybe some good information about what that means, about what that diagnosis means. But it's not going to give us information about how the child is using their vision functionally across their own day and in real world situations, less clinical environments. And it's not going to give us an educational approach or plan to making progress in their visual development. A functional vision assessment is what you need to do that. And a functional vision assessment is provided by a teacher of students with visual impairments, a TVI. Why is CVI so important to identify and assess? What's very unique to CVI is that, as opposed to ocular visual impairments, is that with specific interventions, educational interventions and functional interventions, we're actually expecting an improvement in visual functioning over time. Basically, we're working with the child to train their brain to make sense of the visual information that's coming in through their eyes. This is not true of ocular eye-related visual impairments. If you think about it, a child who is blind from or has low vision from an eye-related visual impairment, we're not expecting their vision to get better over time. Rather, we are expecting to teach them skills to compensate for the fact that they have a visual impairment, access information anyway, and in spite of that visual impairment, and succeed in life. In CVI, we're actually working to improve vision. So this is where I like to say to families, this is really exciting. And this is where, getting that diagnosis is not you shouldn't think of it as a negative thing. It's more like, here is an area where we can add some expectation, not just hope, but expectation for progress and improvement over time. It has to be based on assessment, functional assessment, and that is because we use very different approaches depending on where the student falls on a range of visual functioning, from very severe impact all the way on this scale towards closer to typical visual function. And it really has to be a team effort. This is probably preaching to the choir, but it really can't just be one person, a vision specialist, providing these interventions. We can't make neurological progress in a 30-minute session with a vision specialist. It has to be approaches that are integrated throughout the child's day and become part of their routine. All of this and more is on a 2-page fact sheet that I made to sort of share this information and get some functional language for everyone. And I've sent that fact sheet along to Kim, along with the PDF of this presentation that you're welcome to have. Okay. A question with regard to getting a functional vision assessment. What if the person needing the assessment is an adult? Very good question. If the person is not of school age, they're probably not going to get educational services, including, a functional vision assessment from a teacher of students with visual impairments. They should still, well, first of all, I should clarify and make the point that anyone at any age with CVI should be expected to make progress in their vision. Progress may be slower, of course, with older individuals, and that's just related to, critical periods of development that would be true of other domains as well, but you should still expect progress. In terms of services, who can provide a functional vision assessment for an older person who is not of school age? That probably depends on local services as to where you are in the world. In various states, it's probably the Commission for the Blind and Visually Impaired. But reach out to me if you have questions and want to try to connect to somebody in your locale. It might have to be like a private individual, like a TVI off hours or something like that, but it would still be important. Oh, very good question. And this is a question that I wish I had like another 45 minutes to talk about. If you have, your daughter has optic nerve atrophy, and optic nerve atrophy sounds like they won't be able to improve vision. Is optic nerve atrophy typical of CDKL5? Optic nerve atrophy is typical of CVI. And in fact, I've heard a neuro-ophthalmologist in California who really has expertise in CVI, Dr. Mark Borchert, B-O-R-C-H-E-R-T, speak about how probably most kids or individuals with CVI have optic nerve atrophy. The problem with optic nerve atrophy is that it's a very vague diagnosis and it doesn't indicate severity. Optic nerve atrophy can range from totally blind to typical visual functioning, no impact at all. It just means that the optic nerves are pale and there's not as much information getting through the optic nerves to the brain. So we need a little bit better of an idea of exactly what's going on with the optic nerve. And if you could get your ophthalmologist to give even an estimate of how severe, say on a scale of 1 to 5, do you think the optic nerve atrophy is? Because in all probability, it's probably not more significant of an impact as the CVI is. Reach out to me if you want to talk more about that. And I have some written language to look at that as well. Great. How do you approach the lack of progress in your child with vision despite hard work at home when the IP is not being followed? Ooh, that's the million-dollar question. There should be progress visually, and that is probably a matter of the approach that is being delivered by the educational team. I can share with you some materials and resources to support better planning with the team and getting that stronger information. You really should see progress. Mark Borchert, B-O-R-C-H-E-R-T. Okay, so this is my little 2-page fact sheet. Run with it, use it for whatever you can. There's my contact information on that as well. There's also links to additional resources and answers to frequently asked questions. Who should be the instructor for the child with CVI? Anyone who has training and experience with CVI, training probably even more than experience because you get experience as you go. But that could be a teacher of students with visual impairments. But I've met, great occupational therapists, speech pathologists, physical therapists, classroom teachers who have a strong basis in CVI. Somebody on the team needs to be like the CVI point person, the person who really is, leading that intervention and getting everyone else on the team the information that they need. Okay. I'm glad we have a little bit of time. I'm going to make sure I stick to half an hour and be done at 12:25. Okay. Please feel free to cut me off if you need to, though. Good question. How do you know what the brain is doing with the information? That's what I'm going to tell you right now. So I'm not a neurologist, so this is about as far as I can take this in terms of explaining what's happening in the brain. But I think it's very important, and it's going to help you understand everything else that's going on and how that might look to your child. There are two primary streams of visual processing in your visual cortex, which is at the back of your brain. And let me know if I need to wrap up by 12:15. I'll just finish this little part. I just know we got started.
You're okay, Chris. If you want to go a little bit over, you're okay to go to 12:25.
Okay, awesome. Just because I started a little bit late.
Yeah.
Thank you so much. All right. So there are two primary streams of visual processing in your visual cortex, which is in the back of your brain. You can think of these almost like roads or highways through which visual information is processed. So it comes in through your eyes, it goes back through your optic radiations, that's where it crosses, what's on the right crosses over to the left, and then it's processed in the back of your brain. And of course, we take it for granted that all of this happens simultaneously and seamlessly if you have typical visual processing. And these two streams or pathways are integrated. They're working at the same time and they're working together. But they actually have separate functions and purposes. And in CVI, they're not working well together. So the dorsal stream is the pathway that gives you information about roughly where you are and sort of the fact that there are things around you, but no information about what those things are. No information about acuity, no ability to classify or, categorize the things that are around you. The dorsal stream gives you information about movement, the rough form or shape of something, whether it's illuminated or not, the lighting, but it gives you no information about acuity or detail. So if you see me on my video right now, I'm holding up a little red glow stick to my right side, about 3 inches from my right eye, and I'm not looking right at it. I'm looking straight ahead. My dorsal stream, which is accessed here in my peripheral vision, is giving me information that there's something there. I can see the rough shape of it, but not the detail. It looks a little blurry if I'm not fixating on it. I can tell what color it is because the dorsal stream gives you information about color, especially bright and saturated colors. And I can tell that it's illuminated, it's lit up, versus if it's off, I can tell that it's not illuminated. I can also tell if it's moving or if it's stable, but I can't tell anything about the little details of it, the components and the features of it. That is information that I can only get from my ventral stream, which I activate when I use eye to object contact or direct visual fixation. I'm looking right at it with my central field. And now I can tell all of these unique features about it. I can tell the little patterns on it. I can tell where each little component is, where the little screw on this is, the top, the bottom, the more detailed parts of its form and shape. And I can even read the logo on there. Okay. What's happening in CVI on the lower side of visual processing, we've got kids who are only using a little tiny bit of dorsal stream processing. They're only seeing things in their peripheral fields. If they're moving, bright or saturated colors, illuminated and very simple, no complex details. As the child makes progress in their visual functioning, they start to notice more things around them, but they're still not making eye contact or fixation on those objects. As they continue to make progress, we start to see emerging visual fixation, as opposed to what I would call visual regard, is looking kind of towards something, or maybe almost looks like the child's looking through an object or through a person as opposed to at them. We start to see eye to object fixation, which is a major milestone of CVI, because as soon as you see that fixation, it's a sure sign that that child is starting to activate their ventral stream and being able to tell what it is that I'm looking at, not just the fact that something is there. Finally, as they continue to make progress and approach typical visual functioning, it's all about strengthening that ventral stream and understanding and categorizing and discriminating what it is that's in front of me. Those are higher order visual processing skills related to recognition, identification, visual discrimination of the features of an object or a thing, and then finally connected to language systems that relate to classification. Okay. So here's a little diagram that kind of shows that a little bit more, and you can see how there's these two streams. In typical visual processing, they're constantly working together. In CVI, they're not working well together, and dorsal tends to develop before ventral. Okay, if all of that seems very abstract and you also are not a neurologist, I'm going to give you a quick little simulation to help you think about what your child is having difficulty processing. So I've got this mug full of pens, and I'm holding it up in my right visual field about 3 inches from my right eye. I'm not looking at it. This is a very complex array of objects in front of me. There are there's lots of pens here. None of them have any bright colors on them. They're white, gray, black. They're all kind of blending together and creating this blur. If I wanted to reach and take a specific pen, let's say I want to get this one right here, this gray one. If I'm not looking at it, not making eye to object contact, I'm only using my dorsal stream, it's very hard for me to get that. I'm going to reach and I'm not going to get the right one. So what could I do to make that complex visual array easier for the child who's really only getting information from their dorsal stream? One thing I could do is I could actually reduce the complexity of the array. I'm taking away all of the other pens. So now there's only one pen, the target pen, for me to get. Let's see if I can get it now. No problem, right? Even using only my peripheral vision and my dorsal stream, I can get it because there's a less complex array. But that's not how the world works sometimes. Sometimes we can't control the complexity of the array in a busy classroom, at the supermarket, at home when there's a mealtime, there's other things going on, and we really can't change the environment to reduce the complexity. In that case, what we want to do is make the target that we want the child to access easier to see. So instead of looking for this gray pen amongst the white, black, and gray pens, I'm going to look for this bright yellow highlighter in that busy array. And again, even without looking directly at it, because it stands out in my dorsal stream as bright and saturated color, it's much easier to access. This is the way we want to start thinking about adapting the world for kids with CVI. Make it easier for them by giving them information that appeals to their dorsal stream. Bright saturated colors, illumination, movement, and reduced complexity. Okay. These are the 10 visual characteristics of CVI. I'm not going to go over them because, that's a whole other hour, but I'm going to share lots of resources for you to sort of get that information. We talked about this range of severity. We express that in phases. Phase 1 is the more severe, 0 to 3 on the functional side. Phase 2 is 3 to 7. Phase 3 is 7 to 10. This is just the scale that we use in functional vision assessment to determine what phase a child is in so that we can help guide intervention, because it's very different interventions for kids in phase 1 than it is for phase 2 or phase 3. One little clarification I want to make here is that there's no such thing as 0. and there's no such thing as 10. I've never seen a child with CVI who has no functional vision. I've seen children who are very, 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 very low on their functional vision, maybe only seeing this bright red glow stick in their right visual field, 1 inch away from their eye, moving with a long processing delay, like a full minute of doing that, and then you see the orientation. That would be fairly low, but it's not 0. There's always a starting point, and we have to find that starting point and build on the child's strengths. There's also never a 10 because you're never going to completely resolve CVI. There's always going to be some impact, but if you're up there in the 8-9 area, that is a very subtle impact. Maybe the child requires highlighters to highlight information on a complex math worksheet or something like that. Okay. I have some videos, but I don't have time. You can sort of see some of these characteristics just in the stills, though. You see this sort of reaching while looking away because it's too difficult to deal with integrating looking and reaching. You see sometimes in more complex activities, like this very busy activity of walking down the stairs, outside in the busy, uncontrolled world, you see the child kind of giving this almost like gaze as if they're not looking at anything. That doesn't mean that they're not attending. It just means that they need to look away in order to deal with the tactile input, the physical input, or the auditory input. However, that same child looking at a backlit screen with bright saturated colors is making eye-to-object contact and really accessing that information. Some more resources for you, just a list of the characteristics with some little tips at what you might be looking for in your child, and then a little blank column to sort of make your own little notes on what you observe. Just some resources on assessment and what's that used for. I don't want to go over it all. I just want to share some additional references I found that are specific to CDKL5. I'm sure there's a lot more out there. And then please do feel free to reach out with any questions, anything I can do to support. I'm always happy to hop on the phone and chat with families or professionals and point you in the right direction. Got my work email there and my personal in case you're trying to get a hold of me. Thank you so much again. I really appreciate you inviting me to join today, and it's just really wonderful to return and spend a little bit of time with you guys in this terrific CDKL5 community. Thank you so much. Appreciate it.